on the Mental Health Wellness Act of 2013.
Good morning, Adrienne Shilton, the County Behavioral Health Directors Association, representing the County Behavioral Health Departments in California. Just wanted to leave you all with a report that we just recently released on the Mental Health Services Act. We wrote this report in partnership with the Darrell Steinberg Institute. And for the 35,000 people that are served in what are called full service partnership programs, which is about 40% of the act, we're seeing dramatic reductions in homelessness, incarceration, psychiatric hospitalizations. And so it's all documented in this report, so we wanted to leave that with you today. And we're committed to releasing these reports to you on a regular basis to show the outcomes that we are seeing.
Excellent, thank you. Next witness.
Good morning. My name is Michael Helmick. I am the Assistant Director for RIMCO, the Racial and Ethnic Mental Health Disparities Coalition. I would like to thank Toby Ewing and the OAC for their support for RIMCO. RIMCO is the leading and oftentimes only voice for underserved and unserved racial and ethnic communities. I'm aware that there's currently a budget shortfall, but if there's a budget rewrite in May or whenever funds do become available, we would greatly appreciate the committee's support of RIMCO and the communities that we serve. Thank you.
Thank you. Next witness, please.
Rusty Sealegs for Mental Health America of California, also on behalf of the RIMCO program, and we're hoping that we can find a way where the committee and the OAC can look to find some money to continue that program, because its future is in jeopardy unless we can find some money somewhere. Thank you.
Thank you. Since you really combined kind of both items, you talked about triage in your presentation. Are there any members of the public that want to specifically talk about the triage personnel piece before I move on? Okay, great. Thank you very much.
Thank you.
Appreciate it. 4260, Department of Healthcare Services. We're on page 10 of the agenda. First up, Community Mental Health Overview. Welcome, Director.
Good afternoon, Jennifer Kent, Director for the Department of Healthcare Services. And I just wanted to start off by saying that the department, with the incorporation of the alcohol and drug and the community mental health benefits, offers both a opportunity and significant challenges as we kind of move forward in this kind of new era of Affordable Care Act. And, you know, we're no longer a state that is talking about how we cover people, or whether to cover people or not, but how we cover people and how we do it in the best way possible. And so this agenda really reflects a lot of both the exciting opportunities that we currently have in front of us in terms of the waivers that we have submitted and that we're waiting to incorporate into our broader waiver, as well as some of the challenges that we have found in our fee-for-service system, which is one of the main reasons why we're moving into an organized delivery care system. So with that, I really want to turn it over to Karen Baylor and her team, and Karen Johnson will be here later to speak specifically on the drug Medi-Cal item, but we are really looking forward to working with both you from a legislative perspective as well as with the stakeholders, which I'm sure will be talking about the various items. So thank you.
Excellent. Ms. Baylor, why don't we have you do both of your presentations on community mental health and the mental health waiver renewal, and then when I open it up for public comment, they can address both.
Excellent.
We'll just roll right through both of your presentations.
Thank you.
You're welcome.
This is Karen Baylor. I'm Deputy Director for Mental Health Substance Use Disorders, and with DHCS, I'm very pleased to introduce Brenda Graylish, who is the Assistant Deputy Director, and Dina Cocos Gonzalez, who is the Division Chief for Mental Health Services. So as you know, there's a great write-up in the agenda regarding specialty mental health services, and it really describes well all of the services that are provided. As you know, specialty mental health is a carve-out of the broader Medi-Cal department program, and it operates under the waiver of the 1915B. We do have not just Medi-Cal, but we also do have oversight and accountability for the Mental Health Services Act. We have 2 grants under SAMHSA, and then we have what we call is a Medi-Cal Managed Care Program, not to be confused with the bigger Managed Care Program. So with that, I think there's a great, as I said, description of all the different services and programs within your agenda, and I don't want to take up your time reiterating that. So with that, I'm going to turn it over to Dina, who's going to talk about the specialty mental health waiver.
Thank you.
Good afternoon, Madam Chair. The Specialty Mental Health Services Waiver Renewal application was submitted to CMS on March 30th. The department requested a 5-year waiver renewal term of July 1, 2015 through June 30, 2020. CMS now has 90 days to respond to our request. They'll either approve, deny, or request additional information. The department anticipates that they'll request additional information. That's just the usual process. That will stop their clock for review, start our 90-day clock, and we'll just continue working closely with CMS through approval of the waiver renewal. You asked how the renewal application addresses CMS concerns that are noted in the agenda. I'll echo Dr. Baylor's comments. I thought you did a really nice job in the agenda of outlining what those CMS concerns are, so I won't reiterate those. But in the waiver renewal document, we talk about comprehensive descriptions and plans for monitoring and oversight. In addition to the activities that occur now and have been occurring, what kind of increased or enhanced or new activities we will include as part of monitoring and oversight. So there are a variety of strategies that we're currently considering, and we did include those in the waiver document that specifically will address CMS's concerns. Some of that includes doing tiered reviews, what we're talking about, which would be more frequent reviews for some counties who have higher noncompliance rates, including focused reviews for some counties who maybe have some difficulties with some of those areas of focus and priority, and then also doing more training statewide and more county specific. A question on how the department, what our efforts are to establish timely access standards for the waiver and our timeline to establish these standards. And the department has worked very closely in collaboration with the County Behavioral Health Directors Association in establishing and identifying what should be some statewide metrics. In doing so, we've come up with a list of what we think those metrics should be and are now working through some of the details of defining the metrics and identifying the data sources and so forth. So we're progressing well. I don't have a timeline. I wish I had a more specific timeline to share with you, but based on our future discussions and the activities that are needed to really look at implementing these statewide metrics, we'll define the type of time frame that's needed to implement those. And as far as where the department is on filling the positions approved in the 2014 budget to improve oversight and of county mental health plans, the department's been working very hard to fill those positions. 2 of the 7 have been filled, but 5 of the positions are consulting psychologist positions, and that classification has proved to be very difficult in recruiting. And so we're really, we've gone out with several recruitments, we've done our own departmental exam, and right now our most recent recruitment effort ended a week ago. And we look like we have a couple of promising candidates that we might be able to move forward with. So the department, based on all these efforts and the difficulty, are looking at the viability of putting resources into a contract for these type of clinical positions so that we can meet our need. You've also asked about CMS suggestions for establishing a process to enact fines, sanctions and penalties or corrective actions as a way to ensure compliance. and what the department's efforts or our response to that is. And the department has been working on developing a continuum of corrective action that will include CMS's recommendations on sanctions, fines, and penalties. But I do want to say we do want it to be a continuum, whereas on the low end, we're working with technical assistance, trainings, and really working closely with the counties. And then on the high end, that's where we would be looking at implementing fines, sanctions, and penalties. So in developing that, we need to establish what are the appropriate timeframes, what are the threshold and criteria of when we would implement those types of fines, sanctions, and penalties. And we'll be working with the County Behavioral Health Directors Association as we work through this process.
Any questions? Finance. LAO. Let's open it up to public comment. Get all your questions in. Okay, thank you very much. Let's move on to performance outcome systems for EPSDT, Medi-Cal Specialty Mental Health Services.
Thank you so much. I'm Brenda Graylish, Department of Healthcare Services. The question asked is regarding the timeline for the performance outcome system and an overview of our budget change proposal that we submitted. I'll start with the timeline, if that's okay. With our timeline, we set forth a timeline when we initially submitted our system plan, and then again our system implementation plan, and the structure of that timeline and all those deliverables hasn't changed, so that's the same. We've accomplished a great deal in the last year. We've really focused on examining our existing data systems. So I'm pleased to announce that as of last month in March, we were able to begin posting our initial performance outcomes reports to our website for our stakeholders to be able to view and use that information. And that was a much bigger undertaking than we originally anticipated. There's a lot of work that goes behind compiling and analyzing those data. So as a result, some of our timelines have slipped a little bit. And so we've adjusted accordingly, but we're continuing on with our efforts to examine our existing data systems, and our partners and stakeholders had provided us with a matrix of multiple indicators for which they'd like to see us provide reports. And so we've been working continuously with our subject matter experts work group to understand those indicators and what it is exactly that they're asking. And then we've also been working with our measures task force to make sure that we have the data available to respond to those requests for those indicators. So a lot of work has been underway, but like I said, it's a lot more work than we originally anticipated, hence the need for the additional research resources in our budget change proposal. And the second question asked about the system plan and the system implementation plan updates. So we anticipate having the system plan submitted this month and the system implementation plan submitted June this year, no later than July. Like I said, we got delayed on some of our workload, and most of the, or actually all of the infrastructure hasn't changed. So everything that we set forth in our original system plan and system implementation plan is the same. All that's going to be updated are the dates. And so really what we're using these reports for is a vehicle to provide updates on all the work that's been underway for the last year.
I appreciate timelines being missed because, you know, the amount and design of the work may have been unanticipated, but the challenge for us with the report coming in June, perhaps July of 2015, it's after this current budget cycle. So if it looks like it's going to be any later than that, I'd appreciate the department letting the legislature know.
Okay, will do. And like I said, you know, a lot of what is going to be included in those reports will be just updates on the work underway. We aren't going to change the infrastructure of what it is that we're doing, just so you know.
All right, that's helpful to know. Thank you.
So I hope that's helpful. Thank you. With regards to the work that we've been doing with the managed care referrals to county mental health plans and having that incorporated into the performance outcome system, we have been meeting internally closely every couple weeks with our managed care partners to have our data analysts meet with their data analysts to understand the data being collected on each side. And so we've done some preliminary work that we're going to be sharing out with our subject matter experts work group at their next meeting to start getting their feedback and opinions on some of the methods that we're using and the decisions that we're looking at or using to analyze those data. So that work's underway, and we're excited to be able to see what we can use with our existing data systems. And then with regard to how we're going to actually use those data to make system improvements as part of the framework that we set forth in the original system plan, we talked about a quality improvement process. And again, nothing has changed with regards to our plan with that quality improvement process. We're still continuing to move forward with developing a framework for that process. Now that we have some initial reports that we've set out to our partners and stakeholders and for ourselves, we're starting to take a look at those data and use those reports to help us start building our quality improvement process, plus looking to see, because counties already have quality improvement, like regional quality improvement committees, to see how we can leverage that existing infrastructure to start working on quality improvement. And just from our initial meetings that we've had, it's going to result in quality improvement to our data as well as to the system. So it'll be a continuous quality improvement loop. And again, we've started drafting some ideas internally, and that's another thing we're going to be taking out to our subject matter experts work group when they next meet to start talking to them about some of the ideas that we have.
Any questions? Any questions of finance or LAO? Any public comment? Seeing none, thank you very much. Appreciate it. We'll now make our transition to drug Medi-Cal.
So with that, thank you, Dina and Brenda, and I'm going to ask Marlise and Don Breger to come up.
Excellent.
So excuse us as we transition.
That's quite all right. Scene change. So I think for public comment, if it makes sense, that we'll do the 3 drug Medi-Cal components together. If there's any members of the public that oppose that suggestion, wave your hand. Okay, seeing none, we'll just do agenda items 4, 5, and 6, drug Medi-Cal overview, provider enrollment, and provider monitoring all
Right.
together.
So we'll do a little bit of changing during that process as well.
Okay.
So really want to introduce Marlise Perez, who is the division chief for our substance use disorder compliance division, and she has been my partner in pursuing our federal partners in a drug Medi-Cal organized delivery system. So I'm going to let Marlise give you the update.
Thank you.
Great. So we are very excited at the department to be pursuing our drug Medi-Cal organized delivery system waiver. We've had quite an extensive stakeholder process that we started our efforts in January of 2014 and have continued them throughout this entire process. We submitted the waiver amendment to CMS, it was back in November of 2014, and we are now at a critical piece of the process where we are working daily with CMS on just last-minute pieces of it. We've submitted, when we submitted the draft terms and conditions, there really haven't been any substantial shifts in what we've been discussing with them. There's just a lot of technical issues that we've been working out along the way. CMS is extremely interested in the use of the ASAM criteria, which is the American Society of Addiction Medicine, because it really creates a framework to have beneficiaries properly assessed to what level of service that they need to offer them not only what they're assessed to need, but where they're going to be receiving the most beneficial treatment. And that's really going to help reduce costs in our other healthcare systems, and also, most importantly, help the beneficiaries have better outcomes. So CMS is very, very interested in the ASAM, and I would say the majority of our discussions with them have been around that. How do we properly implement that? There is no other state in the nation that is using the ASAM criteria like we're proposing to do, so it is very new and exciting to CMS. They're also very interested in how we're going to incorporate all of these levels, because that's going to be a very big shift for California, because currently we only have the outpatient services and our narcotic treatment program services and very small residential for our perinatal population. So what this waiver is looking to do is expand the services that are offered, but also to who can receive them. And as most of you may know already, one of our largest restrictions has been the IMD, the Institute for Mental Disease, and the nation is struggling with that. And with this waiver, CMS is going to allow us to reimburse for services in residential facilities. And it's not just being reimbursed for the drug treatment, it then enables that beneficiary to receive if they need other physical health services, dental, mental health. So this is a really dynamic piece of the waiver to be able to test this out, but it really needs to be in this continuum of care of services, and it's wrapping around that client to make sure that they're receiving their mental health services, their physical health, and really looking at whole person care. So it's very exciting. We're really expecting probably, hopefully in the next few weeks, to receive approval. We need to work out these technical issues and then get a final approved version of the STCs. After we receive approval, we will begin implementing in a regional approach. Back in January of this year, we asked the counties who was interested in opting into the waiver, and we were excited to hear that 53 of the 58 counties expressed an interest to opt in. It is the county's choice. They may choose, after really looking at their system, that they're not ready to participate in the demonstration waiver, but there has been a tremendous amount of interest and excitement. Due to the overwhelming response that we received, we are proposing to do a regional implementation for a number of reasons. One is we're going to start in the Bay Area. They have the most sophisticated system of that continuum that I was talking about. And also, we want to make sure that there's limited beneficiary disruption of services, and having the counties next to each other just really helps in that. If a beneficiary lives in one county but works in another, they may need to receive services in that other county, issues like that. So our proposal is, after receiving approval, a county will need to submit to the department an implementation plan. The department will review and approve that plan, and the county will also need to have an executed contract with their board and have the ASAM training completed, and then they will begin the waiver services. And so we have a four-phased approach at this point. We're going to start in the Bay Area, then we're going to move to the southern counties, and then we're going to do the Central Valley, and then the northern. And when we talk about that, it's not that all counties in that phase have to be up and running. It's we're going to just concentrate our efforts, have regional meetings, and help the counties get moving and on board, and then move to the next region. Because the waiver is about 5.5 years, and we really want to get counties up and running.